I'm really excited, frankly, that CompHealth chose the evolution of healthcare as the topic for this conference. It's super interesting to follow the developments in our industry, but I can't help but be frustrated that the reason there's so many fascinating developments is because there are so many fascinating problems. There is so much going on in healthcare right now that it can be all too easy to fixate on those immediate pressures to our funding models. Namely the sequester, bundled payment models, Medicare reform, state exchanges, the list goes on. Don't get me wrong, I'm not saying that you don't have to keep an eye on these things, you do. But by themselves, they're not even close to the whole story. The truth is, and this is really important for us to recognize, if Obamacare had never been enacted, if Romney had won, if McCain had won, we'd be here today having the exact same conversation. Our research has convinced us that these new imperatives that are pushing the healthcare industry to reorganize itself and to form new partnerships, moving from a world of independently operated parts into silos, as it were, into a true system of care. If we don't do this, if we don't become a true system of care, we're convinced we'll never provide a product that allows us to make money in a world dominated by Medicare and Medicaid. Our research has also shown you that it's you, the hiring executives and administrators, who are the people who are empowered right now to create change and to help your hospital become a true collaborative system of care providers. And that's what I'm going to talk to you about today. From a patient's perspective, the only thing that they want to buy is treatment when they're sick and health management when they're not, or not as sick. And those silos, they're inputs, just like the cup and the lid and the beans. If we take a step back and look at the healthcare system the way a patient does, it becomes abundantly clear that the value a system delivers doesn't derive from aggregating distinct businesses under a common corporate umbrella. It comes from synthesizing all of these components into value-added products, into care that patients actually want to purchase. Now, again, viewing healthcare from a patient's perspective, it becomes obvious that at the center of the care enterprise is the physician. The physician is the person who's in charge of care planning and coordination and delivery. These are all the value-added processes that define a system. So it's no wonder that we're seeing right now a massive scramble in most markets around the United States to hire or align physicians. And I'm betting that if this isn't making your job harder right now, it will be in the near future. Added to the mix, as you see on this slide, it's not just hospitals that are in the game now. Payers have realized the value of having close collaborations and the value of integration. And they've been quickly buying up physician groups. Frankly, traditional physician alignment has focused on contracts that we have. And those are to support discrete business goals. Now, it may be more referrals, or it may be extra coverage, or from a doc's perspective, it may be financial security. And these are all laudable goals, but these contracts have tended to ignore issues of integration with the larger system. So most hospitals have ended up with a panoply of individual, customized contracts that tie specific hospitals or specific physicians together around a centralized hospital hub. It's sort of the hub and spoke notion of tying our docs to us through their contracts. It's aggregation. It's not integration. Think about how you describe the doctors within your system, not the ones that you're hiring, but the ones that you've already brought on board. Just think of a few words that you'd use to describe them, and I won't make you say them out loud. You can keep it in your head. Now think of how they describe the hospital. It may be some bad words that are in your head right now, but put those aside. We're talking about a general view of the hospital. As the quote you see here points out, as long as any of us think in terms of us and them, we've got a long way to go. My goal today is to get us beyond thinking in terms of us versus them and thinking as a collaborative care enterprise. So this is what I'm going to discuss. for the remainder of our afternoon together. 11 imperatives for building the collaborative care enterprise, and what you specifically, what you as hiring executives, what you as hospital administrators can do right now to affect change, and how you are really in the center of creating this change, because it all starts with that decision about who you bring on board. What kind of doctors do I need to bring on board to serve that population? So this strategic planning exercise, it ideally is going to start at a board level, but you're going to need to get involved really quickly so you can add your input about the attributes and physicians that you want to hire, because it's the hiring decision that's the make or break point for whether a hospital is going to evolve, whether it's going to turn into a system, a coordinated and a system of seamless patient care, or whether it's not going to be able to meet the needs of this new market. You know, if you don't hire the right docs to begin with, you're not going to be able to make this cultural shift. So you are the ones who are empowered at the very beginning to help your organizations move in the direction that they want and need to move. One is we need our physicians to be power users of information. And I'm not just talking about willing to install an EMR or eventually become a meaningful user so you don't get dinged by CMS. I mean, we really want them to be in tune with questions of value. We want them to understand what is the cost that this procedure is going to have to my system as well as to my patient. Doctors who are open to and even eager for transparency, because it's transparency that we've seen that's been that guiding light towards improvement. Now, physicians are always going to have an independent streak. It's sort of in their nature. But I just want to emphasize the fact that we can't have someone who's so independent that they're afraid of transparency. We want to find doctors who are running towards transparency. As the industry moves more and more into risk-based contracts, and I think you're going to hear about this in one of the presentations tomorrow on healthcare reform, because we really are seeing folks move into risk-based contracts. That's the Medicare shared savings programs, ACOs, bundled payments, and so on. Physicians who understand their impact on overall system performance are going to be extremely valuable to you, and you're the gatekeepers. And I would say that very importantly in this new healthcare world, you want the team players. It used to be that we went out and recruited surgical all-stars if we wanted a real money maker for a hospital, and that's just not how it is anymore. What we want to do is go out and recruit physicians who play well with others and who will be a part of advancing this cultural change and advancing collaboration among their peers. So recruiting the right physicians, those who are a good fit culturally and clinically, is actually just the first step in creating this compact with our physicians. And what I want to turn to now is the how of developing a unified strategy. And again, the how of what you can do to create this unified strategy. Moving towards systemness means finding a way to integrate our physicians into system strategy, not as pawns of the system, but as true partners. When I looked at organizations that were doing this well, I noticed that they tended to excel in three distinct areas. And the first is they involve physicians in a meaningful way in strategy setting, and they did so from day one. They didn't just involve physicians who had been at the organization for a long time. I want to talk about communication, because no matter how strategy is set, it can't be effective unless everyone knows the goals and the plan to reach those goals. Let me give you a personal horror story about what happens when you don't effectively communicate. It's not a hospital story, it's actually a pharma story, but I think it does a great job of illustrating, with a hat tip to Paul Newman and Cool Hand Luke, and I get to use my southern accent here, a failure to communicate. So I was representing a major pharmaceutical company in the midst of a massive recall of their products and the resulting congressional, FDA, and state and federal criminal investigations. It was a really big issue. And we had found out that they actually had a tiny recall. I think it was like 9 months before this massive recall. Now, since this tiny recall had dealt with a regional product, an executive in charge of that region had made the decision to have this firm go into stores and see how much of the product was still on the shelves, so they could determine how big of a deal this was and work with the FDA to come up with a way to deal with the issue. What actually happened was that a manager hired people to go into the stores in the region, but since he misunderstood the goals and didn't know the why he was doing this, he told them to pose as shoppers and buy up all the impacted product. And this looked really, really, really shady. And all of this could have been avoided if they had done a better job of communicating the plan, and if the person who was in charge of executing the plan understood the why. So looking at effective communication models more closely, I think we can narrow things down and say that they share basically a few common traits. The first is that information shouldn't be something that physicians or you or anyone else should have to work to find. It should land in your laps on a regular basis. The second trait is openness about absolutely everything the system is doing, no matter how small, is key. Hospitals that are transparent about everything have far better cultures, and frankly, we've seen this tie to clinical outcomes as well. And third is the constant over-explanation of why we're doing the things that we're doing. So how do we find these core group of docs whose voices we want to amplify? Well, I think the attributes you're looking for is that these are people who are respected by their peers for their clinical skills, but also have soft skills, like the ability to resolve conflicts, or they're good public speakers, or they're generally just kind of nice folks that you want to spend time with. So when you're thinking of hiring physicians, or for permanent or locum positions, I think you're going to want to be very intentional about saying, is this doctor someone who would become part of this core of ambassadors that will help be a part of the solution and not part of the problem? And docs in a well-integrated system understand that their activities, not only drive their personal performance, but also contribute to organizational outcomes. And it's that success, the system success, which in turn actually drives their personal rewards. It's flipping the culture from an old fee-for-service model where I was just paid on what I did to I receive a bonus for how my overall system performance is, so I'm going to care how the other doctors in my group perform. Basically, it's the difference between seeing your job as a doctor as an individual sport or as a team sport. The new healthcare model is a team sport. Now, I'm about to say something on compensation that out of context I think you would think is wildly controversial, but I'm going to say it anyway. Hospitals and systems universally tell us that compensation really doesn't matter that much. Are you scandalized? Let me unpack it a little bit. Those same hospitals also tell us universally that they pride themselves on providing market-level compensation and rates of pay. But, and here's the kicker to this, when it comes to using compensation as a lever for behavioral change, these hospitals do so very sparingly. Generally, they do so to impact behavioral change only in 3 very particular circumstances. You can see them on the slide. It's first when they've tried other mechanisms that failed. Second is to put their money where their mouth is, and this is really important. It's a significant signal of how important a hospital thinks something is if they tie money to it. And finally, and you'd be surprised how often this is actually the case, it's when they have to eliminate legitimate obstacles to achieving a goal. In other words, it's when compensation itself is the barrier to critical change. So here's some takeaways for you if you're involved with setting compensation or if you want to bring it back to your organization to talk about. Keep it simple. we really don't want to pay for every behavior that we want. We want there to be cultural changes, and we want a good culture in general. So there's no reason for 100 mini bonuses. Pick a few large areas and work around there. And finally, while incentives are ultimately about encouraging individual action, tying some portion of them to system goals really helps further integration. And I think that's probably the key take home. I hope by the end of this very brief section, you'll see your role in instituting patient-centered care. Being a patient-centered system and hiring the full-time or locum physicians who share your cultural values is going to be very challenging, and it's going to take some time. So let me be clear of what you're going to be asking of these physicians that you bring on board to be a part of this collaborative care enterprise. You're going to be asking them to move out way beyond their comfort zones. You're going to be asking them to abandon the independent mindset inculcated in years of practice and in medical school. And you're going to be asking them to instead embrace communal notions of success and to embrace financial outcomes that depend on more than just volume. In essence, you're going to be asking them to fundamentally reshape their perceptions of hospitals, of your hospital, and how they relate to their colleagues. But the way forward, I think, is clear, and that you as healthcare professionals, as hiring professionals, as medical leaders, are going to need to make some of these really tough decisions to drive change, even when they seem unpopular with your other physicians or other executives in your institution. So here's the take home. Don't forget that these changes are being made so we can improve care. Once you prove to your stakeholders that we're making these changes so that we can improve our patient care, I truly believe that you're going to get an enthusiastic buy-in. So I'm going to leave you with this. This slide does not have our flashiest graphics, but these are the 3 most important things I'm going to talk about today. So I would even encourage, if you're going to take anything with you at all, rip this out of the slide deck, and you can post it up on your deck, on your wall when you get home and talk about people. Because if you boil down this hour and a half I've spent with you into 3 points, it really would be these 3 points. And the first is this: we need to get beyond an attitude of us versus them. And that's whether the us and them are administrators and physicians, PCPs and specialists, employed docs or independents or anything else. There is no room for factionalism in the value-based world. Factionalism is the enemy of high-quality care, and factionalism will lead to disaster in the value-based funding models that we're seeing pushed upon us. Second, we really do need physician-oriented leadership. It doesn't mean that all our leaders need to be physicians, but it does mean that many, and frankly more of our leaders, will be physicians, and you're going to be responsible for bringing them on board into your organization. You're also going to be responsible for ensuring that you prioritize collaboration and partnership as key values that you look for in the physicians that you are hiring. And finally, I think we need to remember that the most critical question is not whether we're hospital-led or physician-led. It's not which silo we belong to. It's not what our compensation model is. It really is, are we patient-centered? Because to bring it home, to close, it's all about mission. Our industry exists for a reason, and it's not us. It's the patients. That's what we're here for.